I got that. Let me just come.
We need two people joining.
Can I talk to?
Yeah. Well, good afternoon, ladies and gentlemen, and a warm welcome from a beautiful Cape Town. My name is Peter de Jong, and with me over here is, as always, the indefatigable Professor Stephen Jeffrey. On behalf of the Pelvic Floor Foundation of South Africa, I'd like to welcome all you to this afternoon's webinar. It's presented by the Pelvic Floor Foundation and sponsored by Abbott. Just before we begin, Kirsten Pillay from Abbott will say a few words, and a special thank you to our sponsors, to Corin of the Pelvic Floor Foundation staff, and also, in fact, to Percy Midley. Percy Midley, and we will introduce in a minute, he looks slightly as if he's having some shades of grey over there, Percy, because it's not so clear. And of course, there's Elna Rudolph. Elna Rudolph is somebody we've heard recently on this platform, and she's been universally acclaimed as a person of great talent, and we thoroughly enjoyed your presentation, Elna. Thank you once again for being with us this afternoon. Now, Percy Midley, as you may or may not know, works as a gynecologist in Durban, and he's also a sexual medicine physician in association with Dr. Katie Sobrine and Morgan Pillay. He's in fact FECSM, which is a fellow of the European Society of Sexual Medicine. Did you know that, Steve?
I don't know what that meant.
And he's immediate past president of SAMS as well. His topic this afternoon, ladies and gentlemen, is aging and sexuality hormone interplay. So without further ado, thank you, Percy, and a special thank you to Abbott, and also, of course, to Elna Rudolph. We're going to ask Kristen to say a few words, please.
Perfect. Thank you, Dr. Young. I'd just like to thank everybody for their time this evening. And I'd just like to say from us at Abbott, we are committed to women's health. We do have products that range from puberty all the way down to menopause, as well as a few other indications that will come soon. And I'd just like to thank you guys for your time, our speakers as well, and our chair for delivering our pledge to continuous medical education. Without further ado, I'd like to get the day started. We just have a short video that we'd like to show you. So over to your side, Karen, and then we can begin. Thank you, everybody, for your time and attention. I hope you enjoy the talk.
Karen?
June had always led an active life, but when she reached menopause, her symptoms caused her to feel isolated, affecting her work and home life. Medical societies recommend menopausal hormone therapy as effective or the most effective treatment for menopause symptoms. But not all MHTs are the same. In women taking estradiol and dydrogesterone, the ingredients found exclusively in Femiston, there is a lower risk of breast cancer compared with other combined MHT. And the risk of venous thromboembolism is lower than in users of other oral preparations, such as norpregnane-type progestogens, or no MHT. With proven benefits for a range of menopausal symptoms, Femiston can help June take back control of her life. Femiston makes her life better in post-menopause. Femiston is the world's #1 brand for estrogen deficiency in volume.
Thanks so much. And again, also from us, I want to welcome Dr. Rudolph, and she'll be, moderating most of this afternoon session. So again, thanks very much, Alna. And I think we can fire away and get started. And Percy, you're welcome to share your screen, and looking forward to, starting the discussion on this topic.
Hi. Good afternoon, everyone. Thanks to the Pelvic Floor Foundation for giving me the privilege of delivering this webinar this afternoon. And thanks to Abbott for this sponsorship, because this talk doesn't involve any of their products, but I think it shows their commitment to continuing medical education. Where am I?
Next slide, please.
Yeah, it's just not moving on my side.
I'm just
You
going
just have to click on your screen, Percy, then it will move.
Yes. Or you could just use there we go.
Oh, okay, yeah. So human beings are actually never too old to enjoy a happy and active sexual life. But sexuality in the elderly is frequently misunderstood, neglected, ignored, and sometimes disapproved. So as more individuals are living to a later life, we are definitely seeing an increase in the percentage of patients who are sexual in the older age group. And medications and other treatments have been developed that allow individuals to maintain a successful sexual function regardless of age. So sexual function is complex, even more so in females. And there are certain endocrine changes during aging, as well as the endocrine disorders, may either directly or indirectly modulate sexual function. And they do this by altering sex hormones or by impacting on the vascular, neurogenic, or psychological factors. So this complex slide shows the many factors that are involved in sexuality, and understanding the context in which a woman presents with sexual concerns is important in determining the optimal approach. So there are multiple factors that are responsible for sexual function, and often you need a combined psychotherapeutic and medical intervention. And it's like what My Sexual Health has created. They have a multidisciplinary team, and you have access to all of these other disciplines that help us in the management. But as clinicians, we just need a simple approach to how to assess female sexual dysfunction. And we just divide it into either desire disorders, arousal problems, orgasmic dysfunction, and issues of pain. But obviously there's overlap, and evaluation must aim to identify the primary component. So how do we define female sexual dysfunction? It's basically persistent symptoms for greater than 6 months, occurring during about 75% of all sexual experiences. It's important that if it's lifelong or situational dysfunction, then you must refer early for sexual counseling, as this indicates a strong underlying psychosocial and relationship issues. And I always say that if you take a history and they've had an active, enjoyable sexual life in the premenopause with subsequent deterioration in the climacteric, that implies an hormonal etiology. So the normal age-related changes in sexual response should not be labeled as pathology. And the only way we call it a female sexual dysfunction if the quality of the sexual relationship is associated with either personal or partner distress. In other words, distress is the hallmark of female sexual dysfunction. So as people age, the prevalence of decreased sexuality will increase with age, but conversely, this may be associated with decreased distress. Not everything about the menopause is doom and gloom as far as sexuality is concerned, and there are benefits such as the reduced fear of pregnancy, absence of the need for contraceptives, and the end of menstrual distress. So what about the role of estrogens? A significant direct effect of estrogen on sexual interest, arousal, and orgasmic response is not supported by the current evidence. But the undoubted efficacy of estrogen in alleviating hot flushes, improving sleep, and maintaining optimal vaginal health cannot be underestimated. And the sexual sensitivity of genital and non-genital skin is also dependent on estrogen status. So oral estrogens, we know, increase the levels of sex hormone binding globulin. So when that happens, you get decreased free bioavailable testosterone. So if you see women with sexual concerns and you're thinking of putting them on hormone therapy, the transdermal options may be what you would consider first. It's important to remember that women with premature ovarian insufficiency should use hormone therapy until the age of the natural menopause. There's absolutely no controversy in this. And it's important to remember that these patients also have lower circulating androgen levels. So many of them have issues of libido and need to be helped. So the lack of desire is the commonest sexual disorder that we see in the climacteric. And because androgen levels decline with age, the hypothesis was, is decreased testosterone related to decreased desire? So to really understand this, you need to break down desire into its different components. And the first component is drive, which really refers to the spontaneous sexual interest. It's the biological component. It's what declines naturally with age and is often affected by medical conditions and medications. The second aspect is obviously one, socialization. A person's beliefs and values shape the sexual nature of that person. And one has to take culture into consideration, because some cultures, when females reach the menopause, it may be accepted that they will not be sexually active, and we need to respect that. The psychological factors, I think, are very important because they create a person's willingness to have a sexual experience. It refers to what we call the motivation, and that's proportional to the strength of the relationship. So to give you examples of this, you can have a lady with low innate desire, but living in a very comfortable, respectful relationship. And once arousal kicks in, desire levels will pick up. The contrary example would be someone who's in an abusive or disrespectful relationship. And even if she has a high drive, there will be absolutely no desire to be sexually active. So understanding the complexities of desire enables healthcare providers to evaluate this. And I just say that testosterone deficiency may be considered among one of the underlying causes. So this slide just gives you a chance to look at the symptoms and signs that one sees with androgen deficiency. And I'll be making this point more than once in this webinar. There is no established cutoff levels for total testosterone or free testosterone that a woman can be considered androgen deficient. So we're going to go over the physiology of testosterone. So the 50% of circulating testosterone in a female comes from ovarian and adrenal production, and the remainder comes from peripheral conversion of precursors. And as I told you, that there is an inverse relationship between testosterone and sex hormone binding globulin. So testosterone may act via the androgen receptor. It has some non-genomic actions. It's converted in some receptor areas into dihydrotestosterone, which is a far more active version of testosterone, and it can be aromatized to estradiol and its metabolites. So total testosterone can only be measured with high accuracy if you use liquid gas chromatography to measure it. But if you use direct measurements of total and free testosterone by radioimmunoassay, they are unreliable in the female ranges. And we only use the latter to exclude high baseline concentrations and supraphysiological levels of testosterone when we're monitoring treatment. So in the perimenopause, what are the sources of the, as premenopause, what are the sources of the circulating androgens? So dihydroandrosterone sulfate comes entirely from the adrenal origin. DHEA is from the adrenal and the ovary. Androstenedione is mainly from the ovary. And as I said to you, that testosterone, 25% comes from the ovary, 25% from adrenal, and 50% from peripheral conversion. Now, what happens when you reach the menopause? The ovary increases its contribution to the testosterone pool. It goes up from about 25% to 50%. So the question to ask is, why would the testosterone levels fall if the ovary increases its contribution? And the reason for that is that the contribution of the adrenal precursors decreases to an extent that it doesn't compensate for this increase in the testosterone production by the ovary in the menopause. So if you look at the menopause transition, estrogen production declines, and often because it declines, your testosterone levels may still remain in the normal range, because when your estrogen levels fall, the sex hormone binding globulin drops, so the available testosterone is often in the normal range. This is very different to the postmenopausal ovary, which continues to produce testosterone. So in a patient who has a surgical menopause, you have a dramatic and permanent decrease in testosterone production. So you have to clinically differentiate the patient who reaches the menopause, a natural menopause, compared to those who have a surgical menopause. How does testosterone work? It works basically by activating brain areas in the limbic system. So that increases desire. It has a direct effect on the genitals. And intravaginal testosterone is also used as a treatment for the genitourinary syndrome of menopause. So coming back to the measurements, as I said, the concentrations in the female range are very small. You need precise, reliable, and accurate assays. Therefore, when you're measuring your total testosterone, you must know what system your lab is using. If they're using the liquid-based chromatography, that will give you an accurate reading. So you must check with your lab what type of measurement are they doing. So the immunoassays, as I said, is limited by significant cross-reactivity with other steroids. And even when you look at testosterone concentrations through the menstrual cycle in the premenopause, they tend to be highest at the mid-cycle and luteal phase. So now we come to the global consensus position statement on the use of testosterone therapy for women. And this was done by many organizations. They came together to form this consensus statement, and they basically looked at the benefits and potential risks of testosterone therapy in women. And the aim was to provide a clear guidance as to which women might benefit from it, and also to identify symptoms, signs, and conditions where evidence does not allow for the prescribing of testosterone. So basically what they said was that the only evidence-based indication for testosterone was for the treatment of hyperactive sexual desire disorder. They also said that there were no real severe adverse events during physiological testosterone use. They re-emphasized that a blood testosterone level should not be used to diagnose hyperactive sexual desire disorder. They also stated in the consensus statement that the safety of long-term testosterone therapy has not been established. They recommended against the use of compounded testosterone, but I'll come back to that later. And the panel highlighted the pressing need for more research and development of licensed products indicated specifically for women. So if you use testosterone and you just raise the testosterone level to within the upper limits of normal for a female, you very seldom get any side effects. And the only side effects we usually see are mild increases in acne and facial hair in some women, but I've never seen any patient with alopecia or clitomegaly or voice changes. What about breast cancer? There are androgen receptors in the breast, and we know that the breast tissue has an aromatase system which can convert testosterone into estrogen. But even in vitro studies, there is evidence of suppression of estrogen-induced proliferation of cancer cell lines. Testosterone therapy does not increase mammographic breast density. And as I mentioned in my previous talk, increased breast density is an independent risk factor for breast cancer. So the available data suggests that short-term transdermal testosterone therapy does not impact cancer risks. But the data from randomized controlled studies are insufficient to assess the long-term breast cancer risk. And certainly there's no data to support the use of testosterone therapy to prevent breast cancer. So women with a prior diagnosis of breast cancer were excluded from our randomized trials that were done looking at hyperactive sexual desire disorder. So therefore, we can't really give a comment as far as its safety without reservation as far as breast cancer is concerned. What about the endometrium? Because it can be transformed into estradiol, people were worried whether it would lead to any increase in endometrial hyperplasia. And to date, no endometrial cancer case has been reported in post-normal women on physiological testosterone therapy. As far as the cardiovascular side effects, there's no real difference in clotting factors. As far as lipids are concerned, if you use oral testosterones, it definitely adversely affects the lipogram. And so oral testosterone is not really used these days. And people are worried about insulin sensitivity because if you know from the patients we see with polycystic ovarian disease where they have high androgen levels, they often have glucose intolerance. But in the transdermal testosterone patch trials, there was no change in the parameters of carbohydrate metabolism. So androgens basically heighten the response to psychosexual stimulation. They cause the external genitalia to become more sensitive, leading to a more consistent sexual gratification, and it induces a greater sense of well-being. But if we're using testosterone therapy, you have to inform your patients that it's off-label. And the choices of products, we basically only have products that was designed for men, and you can get compounded subcutaneous testosterone implants and compounded testosterone products, but the patient needs to be aware that it is off-label therapy. How do you assess efficacy? Well, the efficacy depends on what mode of therapy you're using. We don't use intramuscular injections anymore. Some of the older gynecologists on the thing will remember medication called Mixogen, which was used on a monthly basis, but it causes spikes and drops in the testosterone level. You get a roller coaster effect, so that's not recommended. You can use testosterone implants, and if you want to assess the efficacy, you see an improvement in about 2 weeks, and you'll see an improvement in the blood level about 6 weeks. If you use patches or creams, you usually get that in 6 to 8 weeks. If you don't see any improvement by about 16 weeks, and certainly if no improvement beyond 26 weeks, that patient needs to be labeled as a non-responder. So is there a role for testosterone therapy alone without any estrogen therapy? Yes, there's no doubt about that, because the study by Davis and them showed efficacy data at 6 months and at 12 months, that not only was the therapy well tolerated, but also resulted in statistically significant improvement in sexual desire and activity and several other modalities of sexual function. So it can be used without estrogen therapy. So the choice of the product is a challenge because in most countries, there are no testosterone products approved for women, except in Australia, where they've now launched a 1% testosterone cream, where 0.5 mils is equivalent to 5 milligrams of testosterone. In the consensus statement, they said if approved therapy is not available, we should use fractionated doses of approved male formulations. And I think the main response when you look for an evaluation of testosterone response is clinical. There should be an alleviation of symptoms. So in conclusion, the efficacy of testosterone, I think, is proven, but long-term safety data are limited. But the available safety data is reassuring since there's been no evidence of increased likelihood of cardiometabolic disease or cancer. And the trial of testosterone should only be carried out after other causes of libido have been eliminated. You should advise women that the treatment should be considered a trial or off-label, and treatment should be ceased if there is no improvement after 6 months. So I think the women who particularly seem to benefit from testosterone therapy are those young surgically menopausal patients, or those that have iatrogenic menopausal group, who feel persistent tiredness and lacking in libido despite adequate estrogen therapy. Androgen therapy appears to give them back their zest for life. So we'll now move on to dehydroepiandrosterone. Yes,
Percy, can I just ask you,
sure.
has any of this changed the way in which you counsel patients regarding oophorectomy, around the time of hysterectomy or whatever other surgery?
Yes, it has definitely changed it. So when I was registrar in training, I think we were taught that any lady that we were doing a hysterectomy, especially over the age of 45, we used to remove the ovaries. And now the teaching is that there's no need, you have to remove about 800 ovaries to prevent one ovarian cancer. So in a patient, you remove the ovaries, even in your menopausal patient, early menopause. If the ovaries are completely normal, you should counsel the patient and ask her what is their opinion, get a family history of ovarian cancer, etc. And if you can, the latest information I've read is it only should be removed if you're performing the surgery in your over 65-year-olds for sure. But prior to that, you can conserve your ovaries.
Okay, so you would just advise a patient under 65?
I would say that, if you under 65, your ovaries are completely normal and there's no reason, then I would conserve it. If she insists on having it removed, I would respect her choice.
Okay, thanks.
Percy, can I just ask a question?
Sure.
We a couple of years ago at SASOG, we discussed this very question with Professor Matthews from the United States. Is there any work of conserving and removing ovaries at menopause and associated longevity? In other words, do women live longer if they have their ovaries conserved, or do they live shorter if they have in terms of cardiovascular side effects?
They live longer if the ovaries are conserved. So the all-cause mortality is decreased in patients who still retain the ovaries.
Okay, thank you.
Right, so you remove the tubes, but not the ovaries.
Yeah, you can remove. Yeah, so that I think is something that we must actually advise. So if you're doing a ligation in a patient, you should remove especially the femoral end of the tube. That decreases the incidence of future serous ovarian carcinomas. And
Percy, I do lots of cesarean sections, and we do lots of cesarean section tubal ligations. How much of that tube must you remove? Because the femoral end is about 2 centimeters. Should you have to take some of this?
I agree with you. In some of them, sometimes it's even technically difficult sometimes to get to the tubes. I do remove the femoral end when I do that. If I can do the ligation, I would remove the femoral end. About, I would say, 2 to 3 centimeters midway through the tube if I can get excess. That's what I generally do. Yeah.
Thank you.
So in DHEA, it's a pro-hormone. It's converted into estrogens, and it's sold as over-the-counter medications in many health shops. Many of our patients use this as an anti-aging supplement, but really the meta-analysis shows little convincing evidence of its efficacy in improving the well-being in postmenopausal women with normal adrenal function. Vaginal DHEA may have a role in reversing the symptoms of vulvar-vaginal atrophy. What about tibolone? Well, this is a drug that's converted into the 3 major metabolites, estrogen, progesterogenic, and androgenic. And it has different effects dependent on the receptors in the different tissues. So the estrogenic metabolites treat all the menopausal symptoms, but you must remember that it doesn't have any favorable effects on the HDL cholesterol as done with normal estrogen, progesterone therapy. The progesterogenic metabolites avoids the endometrial stimulation, and the androgenic component has a positive effect on libido and sexual function. So this is an approved product. So if you're feeling uncomfortable with using an off-label product, this may be, if you've got a patient with sexual dysfunction, this may be a product to start with. But my clinical experience has been that not all patients that have used tibolone have had a definite improvement in sexuality. So even those that have had on tibolone that I've started, some of them have had to resort to using testosterone therapy where indicated. We've spoken about this in the last webinar as well. But
Percy, sorry to interrupt. Can you just go back to Tibolone for a minute?
Sure.
You've mentioned it has an estrogenic, progestogenic, and androgenic effects.
Yeah.
What is it for bones? Does it in any way cause bone sparing, or is there no positive or negative effect on the bones?
Definitely has a positive effect on bones. So its effect on bones is very similar to conventional hormone therapy.
Okay, thank you.
Okay. So when you look at vaginal atrophy, this is something that I always try to emphasize whenever I do, because it's, as I said, underestimated, underreported, and undertreated. And it's so easy to treat it. And the societies have changed the name to the genitourinary syndrome of menopause to emphasize the urinary component. In patients that have it, it even accentuates erectile dysfunction. It may prevent single women from entering a relationship. And about 1/3 of women suffer from vulvovaginal atrophy despite systemic hormone treatments. So that's this diagrammatically showing the thinness of the vaginal epithelium. So the International Menopause Society said that treatment should be started early. It needs to be continued to maintain the benefits. So it's lifelong therapy if you're really using it for the right indications. And all local estrogen preparations are effective, and usually patient preference usually determines the treatment used. If you delay in starting local treatment, you will reduce the degree of response. And initially, you need to start with the initial loading dose to stimulate receptors, followed by a low maintenance dose at least twice a week, I would think. Additional progestogen is not indicated when you're using appropriate low-dose vaginal estrogens. So the main treatment of vaginal dryness is local estrogens, but there's a big role for vaginal moisturizers and lubricants. And I think Dr. Elna Rudolph spoke about this in a talk on sex and the menopause. And I'll just mention a few facts about vaginal moisturizers. So for vaginal moisturizers to work, they need to be used consistently several times a week. They hydrate the vaginal mucosa and they improve the balance of the intracellular fluids in the vaginal epithelium. And in some cases, even restore the acidic vaginal pH. But the benefit is dependent upon regular usage rather than from a specific formula. In the past, I used to use Replin's gel, which I find very difficult to get from pharmacies now. So now most of my patients get Hydro-V, which is based on a hyaluronic acid. And I direct them to the My Sexual Health website, and they can just order this from there. Vaginal lubricants are different. They provide comfort during sexual activity, and you get water and silicone-based. The silicone-based lubricants have the advantage that they tend to adhere to the mucosa. They prevent irritation and potentially avoid mucosal tears. And if you alleviate the pain, then you get improvement in all domains of the sexual response cycle. So this is used only during the act of sexual intercourse. So it's used on a PRN basis. There are some new products that have come out into the market to improve sexuality and libido. So flubenazine, which is an antidepressant, which increases dopamine and norepinephrine and decreases serotonin levels, so it increases the good feel hormones. It's a daily medication. You only see a benefit after 3 to 4 weeks, and this has been approved and being used in the United States at the moment. So it's really the first drug approved to treat flagging libido for either sex. Its main side effect is that of low blood pressure, fainting, and dizziness, and it's contraindicated with alcohol. So in the United States, when they use it, you have to sign a consent form saying that you will avoid alcohol. So that's one of the new products available there, not yet available in South Africa. And then we have this BMT, which is an analog, basically naturally occurring peptide. It activates the melanocortin receptors, but the mechanism of action is not known. But this is used on a PRN basis whenever necessary, like how a male would take Viagra or a PDE5 inhibitor prior to sexual activity. It's a 1.75 milligram subcut injection, and it's given about 45 minutes before sexual activity. This was approved by the FDA in June 2019. So I just thought I'll mention the two products that are in the pipeline. I think we must not forget the value of sex therapy. This is a specialized form of counseling. It is mainly aimed to improve coping skills. It induces cognitive or behavioral changes to minimize the sexual fallout from medications and medical conditions. So there are many interventions available. The psychological education, there's couple exercises such as the sensate focus. And when Dr. Elna did a talk on sex and the menopause, she described in detail the Plicit model, which I think is a great way of when talking to our patients, and it's a way of discussing it and allowing them. And sensate focus is one of the you can refer them to sites on websites which can teach them about it. You may have to send them to psychologists for cognitive behavioral therapy, and mindfulness is now the buzzword in psychology. So those are many other avenues that we may need to send our patients for. So when do you refer your patients for psychosexual counseling? Well, it will differ from clinician to clinician. It will be whenever you reach your level of comfort and expertise, but especially if you find there are relationship issues, and the patient must wish and accepts referral. I seldom will make a referral now for a patient myself. I would give them the details of the person that they want to make the referral to, and they must do the appointment themselves, because when I used to do it initially, they would often default on these appointments. So in conclusion, the role of estrogen for the alleviation of hot flashes, ensuring better sleep patterns, less fatigue, its role in the treatment and prevention of vulvovaginal atrophy may be enough to reverse a negative sexual cascade. And I would say that sexual health is a fundamental human right, and age must not be a barrier to sexuality. And we really need to improve our skills in order to provide comprehensive care, especially in the appropriate management of female sexual dysfunction in the elderly. So I'll end by saying that Meryl Streep said that you have to embrace life getting older, because life is precious. And when you've lost a lot of people, you realize each day is a gift. Thank you very much.
Thank you very much indeed, Percy. Would you like now, Dr. Elna Rudolph, to do a comment, please?
Yes, thank you, Percy. I feel that you've preached the gospel, only the gospel and nothing but the gospel. Thank you very much. I agree with everything that you've said. Thank you, Percy. I know that there is extreme resistance against compounding, and with good reason. Karen, if you take off Percy's pin, then I think all of us will be visible on the screen. Otherwise, it's just Percy on the screen for the, there we go. Thanks. So the reason why we're worried about compounding is because we don't want people in their garages to be making hormones and then us as clinicians selling that to our patients, or telling them to go and buy it. But the problem with giving patients testosterone has for a long time been because we didn't have a product available in South Africa that we could give women testosterone with. But there's an international consensus statement that Percy referred to that has been endorsed by 5 international organizations to say that it is safe to give menopausal women testosterone. So we definitely do not need to be that afraid of it. What I can tell you from my clinical practice is that 1 in 10 will super absorb the testosterone or be poor metabolizers, and then they end up with super physiological levels of testosterone, which we know is dangerous. It will cause abnormal levels of it can increase their cholesterol. It can definitely cause masculinization, which is a irreversible side effect. So I am a firm believer in actually monitoring the levels. I monitor the levels very closely. Although we don't have the greatest assays, at least you will be able to pick up those who go too high and then advise the patients to change the dose. But I just want to make a comment about whether we should be prescribing the testosterone that is commercially available for men now, which is called androgel, or should we be prescribing compounding? So let me explain to you about androgel. Androgel comes in a sachet that looks exactly like what you would get your tomato sauce in if you go to a takeaway shop. And the correct dose for a female is 1/10 of that sachet. Now, if you tell a woman to go and take a product that she needs to use 1/10 of a sachet, 1 sachet over 10 days, And that is it has a very like it is exactly like hand sanitizer. There's a lot of alcohol in it. So it works well. I do have many females on it, and it does work well. There's nothing wrong with the product. It's a safe product, and it is what the international consensus statement suggests, that we actually give our patients that. But you need a woman needs to use 1 sachet for 10 days. And then you measure the levels, and if that's not enough, some of them use 1 sachet for 5 days. Compared to a compounded product by one of our compounded pharmacies in South Africa. And we do have a small handful of excellent compounding pharmacies in South Africa that adhere to international guidelines. They are absolutely top notch. And they prepare a product that the person uses like 1 click or one, like a pump. 1 pump or 1 click or 2 clicks, and that's the exact dose. So for me as a clinician, I feel it's more ethical to give my patient a product of that I know that they will be using the correct dose than to tell a patient to use 1 sachet over 10 days. But I don't think that there's anything wrong with either. It depends on how well are you going to inform your patient, what's accessible to your patient, because the difference is also Androgel, they can get on an original signature prescription from you. It's a scheduled medication, but they can get it from their local pharmacy, whereas a compounded product they need to order online. So it's a practical thing. But I do not think we should have, or we need to have such a high resistance to giving symptomatic menopausal women testosterone. We don't give just any menopausal women or all menopausal women with low testosterone testosterone. We give it to symptomatic women with low libidos. We give them testosterone.
Elna, thank you very much indeed for that. We have hello, Elna. We have a question here from Habib M. Habib, and he says, how do you divide up, is it 50 milligrams of Androgel into 10 doses? Is there an easy and acceptable way of doing it?
This is what I tell my patients. When you do baking, you have a 0.5 ml little scoop. So they can use that. So to squirt out 0.5 mils out of the 5 ml sachet, and then out of that little scoop, use it. Or they can take a syringe and they can draw it up with a syringe, either with a needle, put a pink needle into the Androgel sachet and draw it up like that. Or some people just take out the plunger out of the syringe, squish some of the gel in there into a 1 ml syringe so that it fills 0.5 ml, and then obviously don't inject it, but just use the syringe as a measure to get to the 0.5 ml. Many people will eyeball it. They know more or less how much it should be, and then they eyeball it. But which is obviously a little bit more risky. I use a lot of Androgel for my trans patients. All my transgender patients, all the trans men start on Androgel. So it's a wonderful product, but they can start on 1 ml and then they go to 2 mils, 2.5 mils. It's a bit easier than 0.5 ml. That is a bit difficult to get out of there. But it's not impossible. And you know how cheap it is. A sachet of Androgel costs between 20 and 25 Rand, 1 sachet. So that means for 75 Rand, you can fix that woman's libido. Now, the psychosexual therapists on our team will be pretty upset with me if I downplayed a woman's libido problems just to a testosterone problem. But the thing is, what testosterone does, a lack of testosterone does, is it actually causes difficulty in becoming aroused. So this is the problem. When women engage in sexual activity and they don't become aroused, we've got excellent research to show that what you trigger in them is actually disgust. And that's awful. I mean, nobody of us want to be in a sexual encounter and then experience disgust, if it is with the person that we love, that we actually want to build a life with and be intimate with. But if they don't have the ability to become aroused, to go from, just like the way we are now, into that aroused state, then you trigger disgust in them. And what then happens is they lubricate even worse. They have sexual pain, they don't orgasm, and they have a negative experience. And testosterone addresses that arousability specifically. So it doesn't necessarily, it's not that great at helping people make time for sex or helping people to say yes. Although we have a lot of data to show that it makes it easier to say yes, it makes it easier to initiate. But the one thing where it really works well is the arousability. So that's what menopausal women often complain about, the fact that they feel dead. They feel unresponsive. And for that particular complaint, testosterone works very well.
Right.
I just wanted to mention that we did have a World Sexual Health Day this week on the 4th of September.
Yeah.
And Dr. Rudolph, you gave some, I think it's tonight is your other webinar. Was it last night?
No, thank goodness. It was on Monday.
Monday,
I
okay.
was, yes, because, on World Sexual Health Day, we had, because the theme for this year is consent. So
Consent,
we
yes,
spoke
I
a lot
just thought
about consent. And look, consent in menopause is also, it's a thing, because some menopausal women have husbands or partners that develop dementia. It becomes difficult for them to negotiate consent, or they're in positions where they're financially dependent, and consent can be quite complicated in menopause also.
Yeah, it's a fascinating subject. Yeah.
I want to just raise a subject that Percy did talk about, and I think for you guys who are the pioneers of urogynecology in South Africa, testosterone is very good for the urogenital tract. All the architecture around the bladder, around the urethra, as it, so you can get testosterone into that tissue around the urethra from the vagina side, and obviously into the vestibule as well. It is very, very sensitive to testosterone. I think we broached the subject briefly during my previous talk as well. So I find a great application for local testosterone in women who have the syndrome that Percy spoke about, genitourinary syndrome of menopause, where they have genital arousal problems. So their genitals feel dead, they dry, they're not responding only to the little bit of Vagifem that we can give them. And if you give them a bit of testosterone to rub into their clitoris specifically, and then also into the vestibule, around the vaginal opening, and a little bit into the vagina, most of the testosterone receptors sit in the distal third of the vagina. So it's easy to get there with a finger. You don't make a big mess. You don't need an applicator or anything. It makes a massive difference symptomatically for these women. And we think that it adds a lot well, there's now a lot of data to show that it adds a lot of health to the urogenital tract.
Okay, thanks for that. That's very nice input. And which preparation do you normally use, Alma?
So I use look, my journey worked like this. I just incidentally worked in the offices of the compounding pharmacy of South Africa when my practice was in Bryanston. So I came to know their facility very well. I mean, in the same building. They've got a world-class facility. So I trusted their compound. And then incidentally, my practice moved to right next door to Fagron, the other compounding pharmacy. But another compounding, which I now use frequently, and the other compounding pharmacy that I use is called Formulate or Lycoderm. They also have a very, very high class facility, and they are in Centurion. So Fagron is in Cape Town and in Joburg. The compounding pharmacy of South Africa is in Joburg, in Bryanston, and then Lycoderm or Formulate is in Centurion. So, I think it's extremely important for us as doctors, if we're going to prescribe a compounded product, we need to take the responsibility to say, this is off-label, these are the risks and benefits of using compounded products. Don't use it willy-nilly. But if you as a clinician feel that there's really an indication, I treat vulvodynia. It's my bread and butter to treat vulvodynia. I will not be able to treat vulvodynia without compounded products. I can't. So I use compounded products frequently, and I think we just have to make sure that we use a company that we feel. And I can tell you, the worries about the inconsistency of the products that you get from compounding, I've never come across it. And I test diligently, religiously. My patients don't get repeat prescriptions without testing. And I don't see problems with quality control with these particular companies that I use. I'm not paid by them. I've got no financial interest in them or anything. But on that topic, I just want to mention something, talking about being paid by someone. So, I mean, I didn't even know that Abbott was going to sponsor this, or that Formoston is made by Abbott. But can I tell you something interesting about Formoston? Formoston, of all of the oral hormone therapies, tends to not increase the SHBG. And you heard what Percy said about SHBG, the importance of not raising that SHBG, because when you do raise the SHBG, the bioavailable testosterone becomes less. And then that woman struggles to feel that arousal, and she struggles to lubricate, and she gets the symptoms of the GSM and the other symptoms of just the one thing that low testosterone does in women is it makes them more tearful. And for those of you who work with women with menopause regularly, you know that's one of the symptoms they often complain of, is this overwhelm that they feel. Like when their kids were small, they were managing 10 activities and they had a job and running the household and everything. And now that they're a bit older, you know, if they just have to do 2 or 3 things on the same day, then they feel overwhelmed. Testosterone, there's great data to show how beneficial testosterone is for that part of their executive functioning. So, and their emotional liability. So, I mean, anyway, back to Formoston, it tends not to raise the SHBG like many of the other oral hormones do, and or hormone therapies do. So for that reason, I think it is, and I mean, we've got great data on the breast safety of Formoston. So as I said, didn't even know that they, I'm not prompted by the company to say that, but I'm here for my clinical experience, and I can attest to that.
Elna, in general terms, you mentioned the gel. Is a compounded gel testosterone cheaper than the other one you mentioned, which is?
No, the androgel, which is the one that is available from a pharmaceutical company, it's the same company that makes Femigel, makes androgel, and that is 25 Rand per sachet, and one sachet lasts a woman 10 days. So like $75 is a treatment for the whole month. Whereas the compounded testosterone that I use from Fagron, I think it's around 250 Rand. But I must say, you know, for my patients, that's not a problem. The difference between squeezing out a little bit every day over, and, you know, I had this experience anecdotally. I had terrible problems with my eyes, and my ophthalmologist told me that, you know, there is this one thing that I can give you, but it's very expensive. And, you know, I could hear like he's keeping it like as a last resort. And then, you know how much it cost? Freaking 370 Rand, and it fixed my eyes in 3 days. And I thought, you know, I should have been offered the 370 Rand option right from the start. So good medicine, you know, now is is shared decision making. That's good medicine. So, you know, you can give the patients all the options, and they can decide whether they want to go for the 75 Rand or the 250 Rand option.
Thank you.
Okay.
Great. Oh, this has been a wonderful session. Was there something else you want?
I just want to support what Dr. Rudolph said regarding the compounded products, because in the past, I've also used testosterone implants, but I've got it from the same source. And when you've used it for a long time and you monitor levels, you get a good feel on whether your products, you're getting a balanced product. So I think that's important to have consistency in whom you're getting your product from, so that you can enjoy it. And I totally agree that we don't really change the stresses for our patients, but if we correct their hormonal profiles, you allow them to react to their stresses in a more rational manner. And I think that's the basis of endocrinology.
Excellent.
Dr. Moodley is joining us from a load shedding area, as am I, which is why I've got my little light on, but that's why he's all dark.
Yeah.
Okay, well,
Thank you
great.
so much, Steve.
No, that's excellent. I mean, it's just been a wonderful session. Thanks to all of you for joining. It's yeah, obviously very nice to have again Dr. Rudolph's insights. Thanks so much for your time and sharing your experience with us, and Dr. Moodley as well. Really enjoyed that, and thanks again to the team from Abbott, and thanks to the fatigable Dr. de Jong as well, who's you know, never fails to you know, keep these webinars going and keep the momentum. So really appreciate that, and obviously thanks to Karen too. So yeah, so I think on that note, I think it's time to sign off.
Just remember, next week is a JDW pathologist speaking about cervical screening. So we hope to have you all over here, Elna. Next week, same time, same place. Safe home. A great big thank you to Professor Jeffrey for allowing the use of his office and, of course, the use of his minibar. Thank you, Steve. And of course, we look forward to seeing you then, same time, same place. Thank you, Corin. Next week, safe home. Thank you very
Thank
much.
you. Thank
Bye-bye.
you.
Thank you. Bye-bye.
Bye.